Good morning, everyone. Thank you for taking the time to join us today on this call sponsored by the College of American Pathologists. I'm Robert Johnson. I'll be your host for this, and we'll be back to talk to you later about calling on you as we go around for questions. Want to just remind you that we have a couple of panelists today who will offer some opening remarks, very short. And we will reserve most of the time for your questions between now and the top of the hour. We will call on everyone in the order that they've raised their hand, so please use that feature in Zoom. And then when you do ask a question, as we get to that part, I'll remind you again at the end to just do us a favor, do the panelists a favor, and let them know who you are and what organization you represent. The session is being recorded. It is on the record, and the staff will put the names of our two panelists in the chat along with their credentials so that you have that. And so with that, I would like to introduce now the president of the College of American Pathologists, Dr. Donald Karcher.
Thank you, Robert. Thanks very much. And hello, everyone. As Robert mentioned, I'm Dr. Donald Karcher. I'm currently the president of the CAP. I'm also professor and immediate past chair of pathology at George Washington University in Washington, D.C. So we're very happy to have you join us for today's briefing on the measles outbreak. As you know, the U.S. is seeing a significant outbreak of measles currently affecting Texas and New Mexico. As of the latest data, there have been a total of 222 cases of measles in the U.S. so far in 2025, and 208 of these cases have been confirmed as part of the outbreak in Texas and New Mexico. It's worth remembering that measles was eliminated as a regular community-acquired infectious disease in the U.S. in the year 2000. Since then, cases in the U.S. typically occur when someone lives or travels outside of the country and brings the disease back with them. Outbreaks of measles, where there is spread from person to person within a community, are uncommon in the U.S. Outbreaks, like the one currently in Texas and New Mexico, with so many patients infected, are very uncommon. Measles was conquered as a recurring community-acquired infection in the U.S. as a result of widespread vaccination of our population against the measles virus. Our strong public health programs, both nationally and in the states, have also contributed to the control of this disease. Now that we're dealing with this outbreak, it's important to talk about the disease itself and how we can diagnose patients with measles and also test people to see if they're immune. Pathologists are physicians who specialize in diagnosing disease using laboratory methods, so this is right in our wheelhouse. We have an expert pathologist with us today, Dr. Ben Bradley, who will shed light on the outbreak and how pathologists and clinical laboratories can help. By the way, we had hoped to be joined by a second expert pathologist, but unfortunately that pathologist has come down with a bad cold. Not measles, fortunately, but a bad cold, and has lost her voice. So Dr. Bradley is going to do the lion's share of our work today. So Dr. Bradley, please introduce yourself and get us started.
Great. Thanks so much, Dr. Karcher. And thanks so much, everybody, for joining us today. My name's Ben Bradley. I'm an assistant professor here at the University of Utah, and I specialize in medical microbiology. And this is a field of medicine that physicians can train in that focuses on the development and implementation of assays to various pathogens. My own area of specialty is virology, especially emerging viral infections. So I've developed assays for things like Mpox recently, also bird flu. In addition to my service at the University of Utah, I'm also a medical director at ARUP Laboratories. For those of you who may be unfamiliar with ARUP Laboratories, we are a national reference laboratory that provides lab testing services not just to the University of Utah, but nationally as well. And I know we have a lot of members from Texas and Oklahoma, and those are also regions where we have hospital systems that we provide laboratory testing for. So I'm going to give us just a little bit of a background on the situation, discuss a little bit about measles virus, and then the tests that we have available. As Dr. Karcher mentioned, really this has all kind of come to a head recently because of an outbreak we've seen in a Mennonite community in West Texas. And since that time, we've seen cases spill over into Oklahoma. as well as New Mexico. And then more recently, there's been some independent outbreaks identified in Pennsylvania and I believe New York as well. So as far as the clinical presentation of measles virus goes, this is an acute viral illness that's typically characterized by fever, cough, conjunctivitis, and then also this very typical rash. This is something that has often been described as being a very typical picture, but the fact is that we see measles so rarely now that often clinicians who see a child with a measles rash will think about potential other causes, more common causes for infection in those patients. Something that's also important to stress about the presentation of measles virus is that folks who are infected with measles virus are incredibly infective to one another. So if you would put somebody who has measles virus in a room with 10 other people, 9 out of those 10 people would end up getting measles virus from that person. That's greater than what we see for influenza. That's greater than what we saw for COVID. So this is an incredibly transmissible virus. And on top of that, patients can spread the virus before they develop this typical rash. So you may have somebody who doesn't even know they're infected yet spreading this virus. While typically patients will resolve after these infections and do well, there are some severe complications, and there are also impacts to the community that I think we need to be aware of with measles virus. So as far as some of the severe complications go, there's an acute kind of severe complication we worry about, which is either developing a severe pneumonia that can cause respiratory failure and death from that, as well as an acute encephalitis or inflammation of the brain that can also lead to death. There's also been some really interesting studies about children who have been infected with measles virus. And what it's shown is that following a measles virus infection, these children will have lower antibodies against other viruses and bacteria that they may have previously been immunized to. And so what this means is that a measles virus infection can weaken the immune system for a longer period than just that acute infection. On top of this, there's a very rare event called subacute sclerosing panencephalitis, also known as SSPE. This is a progressive degenerative neurological condition that is uniformly fatal. But this often, or in the rare events where this does occur, this can happen 10 years after the virus infection. So the virus is no longer present in the person's system, but still causing severe disease. At a community level, why we worry about measles virus is because not everybody can be vaccinated against measles virus. So the vaccine uses a weakened form of the virus that's still able to replicate. And so certain individuals, especially those who may be receiving chemotherapy, those who have undergone transplants, can't receive these vaccines. And it's important that we have the community vaccinated against this because we need about 95% vaccine coverage to make sure that measles can't spread because of how transmissible it is. So those are really our clinical concerns and presentations of measles virus. So I think what I want to stress is that this isn't just a one-time respiratory illness that comes and goes. There are many downstream implications from this infection, both to the individual and to the community. So what can we as laboratorians do as far as testing? I think a lot of the testing infrastructure now, you're probably very familiar with because we talked about a lot of these during COVID, and we have a similar armamentarium present here for measles virus. So one of the assays we have available to us is PCR testing or NAT testing. And this can be done to detect the viral RNA that's present in samples. Typically, we take samples from either the nasopharynx, the oropharynx, or the throat. We can swab there and test for the presence of the virus. The one challenge with that assay right now is because of how infrequently we see measles, this is not a test that's widely available. It's not something that commercial manufacturers typically produce tests for. So testing is mainly available through state, local public health offices, the CDC, and some specialized laboratories. In addition to PCR testing, another kind of group of assays that we have available to us are serology tests. And historically, serology tests have been kind of the backbone of measles virus testing. And with serology testing, we can look for one of two different targets. The first target we can look for is something called IgM. this is an antibody that's formed early in acute infections. And typically we're able to detect this within the first 72 hours after a patient develops their measles virus rash, and this stays positive for about a month. So we can often use that in a patient to see if they've been acutely infected. The other antibody we can test for is something called IgG. IgG are our long-lasting antibodies. And we can use this to test patients to see either if they've previously been infected with measles virus or if they've been vaccinated against measles virus. So if you have someone who has an unclear history of vaccination and they're wondering if they need to get boosted, they can be tested for measles virus IgG, and we can see whether they have the antibodies necessary there. And if antibodies are present, we assume those to be protective against the virus. And so those are really the tools that we have available to us in the laboratory to help combat this outbreak. And I think those are the major points that I'd kind of like to start us out on, but happy to open up the floor for questions now.
Great, Dr. Bradley. Thanks very much. A nice overview. So Robert, maybe you could lead us into the questions.
Absolutely. So just a reminder that if you do have a question, please raise your hand and allow us to call on you in the order that you've raised your hand. And also, when you do ask your question, if you would just do the panelists a favor and allow them to know who you are and where you're from, what organization you're representing, that would be great. So we have a lot of folks on the line today and looking for our first question.
You know, Robert, I might lead out with a question for Dr. Bradley. Dr. Bradley, you mentioned about serologic tests and how they can be used to see if a person may have currently or may have previously had measles. Can you talk a little bit about how those serologic tests can be used to determine if a person is immune? And would they might be eligible for vaccination, or they may not need vaccination? Can you maybe elaborate on how that test is used for that purpose?
Yeah, so with those tests, I kind of mentioned how we have these two antibody classes we look for, IgM and IgG. And for a patient who's been vaccinated, they will have IgG antibodies present within them. And so we can perform a test where basically we use a component of the surface of measles virus and we add the patient's blood to this well. And then we're able to detect a signal that's present if this patient has antibodies. And typically we'll assume that if this patient does have those IgG antibodies, those are protective against the virus.
So that's how a person could be determined if maybe they didn't know if they were vaccinated at some point. And so they can be tested for that to see if they have the IgG antibody. And that antibody normally would stay present for life.
Correct. Yes. We receive 2 doses of the measles virus vaccine, and we typically assume that provides lifelong protection.
Great. Robert, I see some questions now. You want to go ahead and get us started?
Yes, let's go ahead and do that. I believe it's Yeon-Sung Kim, I hope, maybe?
Yeah, it's Yunsen Kim. I'm with ABC4 Utah. Thank you so much for calling on me. I actually have 2 questions. So it seems like within the first 3 months of 2025, we've already gotten close to what we've seen with measles outbreaks in the full last year. I was wondering the reason behind this acceleration of infections. Also, the second question is, because our newsroom is located in Utah, I was also wondering the chance of a spillover in the state of Utah as well. It seems like we have a 91.7% of vaccination rates. And I believe Dr. Ben Bradley mentioned a 95% would be ideal when it comes to prevention. So those 2 questions.
Yeah. So those are both great questions, and let me make sure I answer both of them. So the question of kind of why have we seen so many cases initially at the start of this year? With any of these outbreaks, you can almost think about it kind of like a tinderbox that happens. When we look historically at these outbreaks of measles that have happened in the US after 2000, after we eradicated measles virus, typically these have occurred in very small populations, groups of people or communities where there is a high amount of vaccine hesitancy or low uptake of the vaccine. And I mentioned that 95% we want, but within these communities, we're talking more 25, 40%, so very low. So because of that incredibly high transmissibility rate from these viruses, we can see that once one case pops up in a community, it can really spread through that community very quickly for those reasons. And that's historically what we've seen with these cases. As far as kind of the threats to Utah in particular, I think there is always a risk if you share a border with someone for that, but I think it's even greater than that. I mean, we live in an incredibly interconnected world now where I can get on a plane and in 12 hours be on the other side of the globe. And if I'm infectious, I can bring it there as well. And we do have lots of international travel. In fact, a non-significant portion of the measles cases that we see in the US are actually thought to have been from imported cases. So somebody in a country that has lower measles vaccine coverage travels to the US, and then that's the incident case that brings it into the US to spread. Something I haven't mentioned that I think does bear repeating right now is that measles virus only infects humans. There are no other animals, there are no other reservoirs for this. So in theory, if we do get to a point where we have complete vaccination coverage across the globe and this virus can't spread, we can actually end measles virus. That's something that we did for smallpox, and it's something that we've been on the cusp of several times before.
So sorry, I just have a quick follow-up. You mentioned about some communities are averse to having vaccinations. And Utah has a lot of rural communities. And I was wondering if these rurality of some communities and the political beliefs make certain communities more vulnerable to measles.
Yes, I think absolutely. So I think, it's not just one thing that causes these outbreaks. Some folks are concerned about the science. Some folks have had bad experiences with the healthcare system previously, and so that's instilled some distrust in them about this. So I think, as physicians, as members of the public health community, it's our job to try to reach out to these communities and figure out what is their concern that's impeding the adoption and try to address those moving forward.
Thank you for that. The next question will be from Luke Andrews.
Hi there, thanks for setting this up. Luke Andrews from dailymail.com. I just wanted to ask a bit more specifically if you had a few more thoughts about where these initial cases may be coming from and coming into the US from. We've noticed that there have been at least 2 cases that have been linked to a China Airlines flight, and then there's been 2 different China Airlines flights, and there's been at least 2 cases as well that have been linked back to Korean Air flights. I'm wondering whether you're aware of outbreaks in either of these countries or any areas of the world that are seeing an uptick in measles at the moment that may be leading to this uptick in the US.
Yeah, I think that is a great question. And I think, unfortunately, I'm going to give you a very unsatisfactory answer. In my own kind of world, I'm not as plugged into some of our public health reporting infrastructures for these things, especially internationally. History tends to repeat itself with infectious disease outbreaks. And so something that, we have seen before is that especially in places where there are civil unrest, where there's political destabilization occurring, that impacts the public health infrastructure. And so children who need to get their vaccines are often missing out on these. And if these populations are moving between countries, moving between borders, that can also sometimes facilitate the spread. However, I'm not aware of, in this current situation, especially with the flights you mentioned, whether that's been tied to a single event.
Any follow-up, Luke, or does that cover it for you?
That covers it. If I could push it a little bit further up on this one, are you aware of any cases in the past where where measles may have been used and seeded into different countries for any particular reasons?
No.
No, no worries. Thank you.
Let me just follow up on on Dr. Bradley's answer to the question about air travel. I live in the Washington, D.C. area. I was just recently at Dulles International Airport. The day before I went through that airport, there was a documented measles case from an international traveler. So this is a real phenomenon, and that case was detected and isolated appropriately. So I'm not sure where that traveler came from, to Luke's question, but it's real.
Brilliant. Thank you all.
Thank you. Haley Hernandez was working on getting a hand raised, but the technology wasn't necessarily cooperating. So we'll take Haley and then Emily and then Jess.
Yeah, thank you so much. I apologize for that. I'm Haley Hernandez. I'm with KPRC in Houston. And so based on everything that we're saying, I'm anticipating that you guys are going to say that you expect that measles will continue to spread. Where I'm sitting at in Houston is pretty far away from the West Texas outbreak, but we are a highly populated city. So I'm wondering how concerned you are about it getting to the populated areas, when I can say that Houston has had measles cases in the past, but typically it's confined to, as we've been talking about, an international traveler, and they're, they go into isolation and then it doesn't really have an effect on us. So are we still concerned if it comes to a really condensed area that this could be a disaster?
I mean, I think there is always a threat of these outbreaks occurring. I think something fortunate is that, these measles outbreaks are severe. There are very big impacts to patient populations. The good news is this isn't like a COVID type situation where we have the entire global population naive to viral infection. So from that standpoint, we're not talking about something as impactful as that at a macro level. At a micro level, this can still devastate communities. And, to your question about, Houston is a mega metropolis. I'm from South Louisiana, so it's a huge city, right? And within this huge city, you have so many different cultures, populations, and people that spread of vaccine coverage is not going to be homogenous. Maybe you say Houston is 90% or 95%, but there are going to be pockets, there are going to be groups of people there where it is 25%, 30%. And if somebody's, having a school event with somebody from this population, if they're having social events, this is such a transmissible virus that even in passing, folks who are not vaccinated against this could be at risk for developing this kind of infection. So I think, when you have a large population and a very diverse population, there's risk that you can have that kind of tinderbox effect where someone comes in and causes big spread within a community.
I did want to clarify a term that Dr. Bradley used. You used the term naive when talking about COVID. That's immunologically naive. I just wanted to clarify, Dr. Bradley, how you were using that word.
But folks who, when COVID first happened, none of us had antibodies to COVID because there was not a vaccine that existed.
Yeah, the term naive is used for that, where people
Okay.
do not have antibodies. Their immune system has not been exposed.
I understand. Thank you
Just
so
wanted
much.
to clarify.
Yeah, great point. Thank you.
Thank you, Haley. All right, our next question from Emily Brindley.
Hey folks, can you hear me okay?
Yes.
Yes, okay, great. So I'm Emily Brindley. I'm at the Dallas Morning News in North Texas. I wanted to ask a bit about some of the homeopathic measures that I've seen folks talking about. Vitamin A obviously is one. I've also seen one, I think it's morbillinum is how it's pronounced. I'm just wondering, Dr. Bradley, if you can talk about any of these homeopathic measures and whether you have any concerns when people are starting to talk about these in response to a measles outbreak.
Thanks so much for the question, Emily. And, I will try to answer this to the best of my ability here. I think something that I do as a physician is try to stay in my lane when I'm speaking about what I understand. And some of these homeopathic treatments I'm not well versed on. I haven't seen data on, so I'm not sure if I can really speak to. As far as the vitamin A, as it's not necessarily a treatment. It's something we would consider as more of a supportive measure from the medical standpoint. And it has been recognized in the medical community that this is something we can supplement for children. The question is, where some of this data comes from to support using these treatments. And the idea of using vitamin A has really kind of come from a lot of studies in more resource-limited countries, not necessarily the US, where our patient population may be a little bit different here. I will say vitamin A is something that medically we're very familiar with that has been used, so we're comfortable with that. I think with other kinds of treatments that folks may try on their own, we really have to advise a lot of caution there if these haven't been studied, if we don't understand how they could interact with other medications that patients on with, conditions that are unique to that patient.
If I could just ask a quick follow-up on that. A lot of the discussion that I've seen about vitamin A and also the other one that I mentioned have been within vaccine hesitant communities. I'm wondering if there has been any kind of change in the way that the public talks about these homeopathic medicines or treatments over the past few decades. I guess I'm just not kind of clear on how much of this is just stuff that people have always talked about to some extent, and how much of it is new that people are beginning to talk about some of these homeopathic measures.
Yeah, I think that's a great question. I think that's something kind of challenging for me to answer as well, because really in my role in the kind of clinical care for individuals, I'm more focused on the laboratory testing and less on the treatment for these patients. But I think, globally, we saw this big uptick during COVID of folks looking for alternative therapies along the way. And so I think between COVID, between social media and the ability for that information to sometimes spread virally, it is my opinion, without any data to back this up, that this has become more common and more frequently talked about and investigated by patients.
Let me just add that although I'm far from an expert on treatment of patients with measles, that my understanding is that vitamin A does not diminish the acquiring the infection. It does apparently, in children at least, is proof that it does diminish the mortality of children that have, if it's appropriately administered. One concern I know that I've read about is that potential overdose of vitamin A. Vitamin A can be toxic when it's given in excess amounts. So, we certainly would not encourage anyone to be self-medicating with vitamin A. But it does apparently diminish the mortality in children, but it does not prevent the infection.
Thank you for the question. Our next question comes from Jess Onsures, I believe it is.
You pronounced that very well. Yes, thank you. Jess Onsures, I'm the editor of the Las Cruces Sun News in Las Cruces, New Mexico. A brief question, if you would. We know of one death among an unvaccinated child in Texas, and one death in New Mexico that may be related to measles, not yet confirmed. I am wondering if, given the rate and the spread of the disease, of the virus, if you might be willing to speculate on how many more deaths or rate of deaths we might expect before we see a decline in the spread of the virus.
I wish I could predict that. It's a bit like predicting the weather. I think, you can have this kind of butterfly effect of one person traveling to the wrong place at the wrong time that can cause these outbreaks. Dr. Karcher mentioned his recent experience in the airport with measles virus cases. So I think it's very challenging to put a number on these things. And I think it's even more challenging to try to put a number on something this early into an outbreak. I think we are still trying to figure out the extent and the number of people involved in this and the number of people being monitored for the disease. So I know I've talked about this several times, and I apologize if I'm reinforcing it too much, but measles virus is incredibly contagious. So 90% transmission rate. For public health contact tracing, if a child has gone to some school event and exposed hundreds of people, all of those patients need to be followed up with and monitored. And no system is perfect. So some of these individuals fall in the cracks we're not able to follow up with. So knowing the true impact of these highly transmissible viral events is challenging. So even the numbers that we're putting out right now, these are confirmed cases that we've been able to document, but we know that the spread is probably greater than that, and this is an underestimation of the true value. What the true value is, I think, is still hard to determine right now.
Let me add that the mortality rate for measles is estimated to be 1 out of every 1,000 patients who are infected, and higher in parts of the world where the healthcare system is not well developed, is as high as 1 in 100 patients. So if these two cases are in fact both from measles, one is proven, one is suspected, that's above the average already. And as Dr. Bradley said, we don't know how many people are going to get infected, so it's hard to predict how many people might die of this disease. Just as a reminder that before the vaccine was widely used in the 1960s, 500,000 Americans in the average year were infected. So if you follow the math, that means 500 or more Americans died each year from measles, if the 1 out of 1,000 rate was true during that time.
Thank you both.
Thank you, Jess. Our next question is from Hannah Webster, and if you have a question, please feel free to raise your hand. We still have some time left in the briefing, and we can get you in the queue. So go ahead, Hannah, and ask your question, please.
Hello, thanks for doing this. I'm Hannah Webster. I'm a health reporter at the Pittsburgh Post-Gazette. I'm wondering what you've seen maybe in clinical practice, what you've seen work in terms of communicating with people who are vaccine hesitant. If there are folks who, have said, no, I, don't think the MMR vaccine works. I think it's related to autism. I think measles immunity alone is stronger, a better way to go about it. How do you have those conversations, and how should reporters be having those conversations?
Yeah, I think it's something challenging. I think it's something that really, from my own perspective, often requires being handled on an individual to individual basis. I think there's not just, if there was one message we could put up on a billboard, we would have done it already. We would have figured that out. So understanding kind of the nuances of that individual patient's concern, especially normally this is a concern for their child, not the patient themselves. And realizing that this is a war, not a battle, that sometimes these conversations need to happen longitudinally over time, where someone kind of begins to feel more comfortable with these messages. I think there is as much data as we can provide somebody, and sometimes we have to be aware that these decisions are coming from maybe a place more of feelings, maybe a little bit more irrational kind of choice, and try to find some common ground where we can discuss this matter on, whether it's, from the perspective of the own patient's health, from the perspective of members of their family who may be at increased risk for severe outcomes for measles virus if they were to acquire it. I mentioned earlier that the live vaccine, the vaccine uses a weakened form of the virus. And so some individuals can't receive that vaccine. So kind of working from that standpoint too, understanding that if you get vaccinated, you're helping protect those as well who aren't able to get vaccinated.
Maybe I could add to that question. Thanks, Dr. Bradley. That's a great response. But, I think one of the things that we've all learned is that a trusted messenger within a community is often the best voice for vaccination. It really needs to be someone that is trusted within the community. And each community has its own dynamic. And we certainly, I believe, learned during COVID that if a trusted spokesperson from that community was encouraging people to get vaccinated, the uptake was substantially higher. We also I talked earlier about the mortality rate, but I didn't mention, and I should, that as we learned with COVID, people with a weakened immune system are a much higher risk of dying, and children under 5 have a substantially higher mortality. And those children under 5 are not able to choose to be vaccinated themselves. So that message brought into a community that unvaccinated children are at a substantially higher risk of dying. That could be a powerful message.
Thank you.
All right, so I don't see any other hands raised here, so we'll give everybody an opportunity if they have a question that they've been thinking about. Now would be the time. Looks like we have one from Courtney Harris, I believe it is. Bond, Courtney Harris Bond. Yep.
Philly voice in Philadelphia. So the death rate has been higher than expected at this point. So could this possibly be, you're saying there's probably we're probably underestimating the amount of cases at this point. So how much could we be underestimating the cases potentially at this point? And is this just the tip of the iceberg that we're seeing, in other words?
Dr. Bradley, I'd love to hear your answer, but I'll just start out by saying that the cases that have been reported are ones that have been documented with laboratory tests. There's a very good chance that there are a lot of people in that community that are down sick with measles but never get the test to document their infection. Dr. Bradley, do you have any insight into that?
Yeah, I mean, I think I agree with you. I think this is, I would say, are we closer to the tip of the iceberg or are we closer to the base? I feel like we're closer to the tip, but I think that's just any outbreak. I think, we're not able to test everybody, and there's many reasons for that. Some folks don't want to get tested. Some folks don't have access to the testing. Sometimes, if there are costs involved in this, folks don't want to be responsible for paying for that. So there are a lot of barriers that exist. Public health can only do so much with the staffing they have available to them for this kind of testing. So I do feel like we don't yet have a full picture of the scope of this measles outbreak. And I think evidence of that is that we're continuing to see cases pop up. We're continuing to see cases spread, because if we would have perfect surveillance, ideally we'd be able to stop this. But as it continues to spread, that just indicates that we are missing cases that are out there.
Any follow-up, Courtney?
No, thank you so much.
Okay, great. Do we have any other final questions from anyone in the group? Anyone else have something they'd like to ask before we go to our closing comments? Okay. All right, well, Doctors Karcher and Bradley, why don't you wrap this up for us, and then we'll offer a few thoughts about where to get the recording and other housekeeping items.
Bradley, any closing remarks?
No, I'd just like to thank everybody for joining us today. I think it's critically important what you all do as well to educate your readers about the threat of measles virus, and then, increasing their awareness of the efficacy of vaccines, the availability of clinical testing to help prevent the spread as well.
Thanks, Dr. Bradley. I'll just add my thanks to members of the press for joining us, and also to you, Dr. Bradley, for sharing your expertise with us. We hope we've given you some information, useful information about the outbreak and about how pathologists and clinical labs can help in diagnosing the disease and also assist in controlling it. I want to certainly emphasize that the best weapon we have against measles is vaccination. But when outbreaks do happen, as we're dealing with now, we do have some great pathology and laboratory services that can help. If you'd like more information or want to do any follow-up interviews, please reach out to the CAP Media Relations staff. I think their contact information, Angela Panettiere and Abby Watson, is in the chat or being placed in the chat. I'm looking to see if it's there yet. It is. Perfect. So thanks again, everyone, and have a great day.
You can also find a recording later this afternoon. A link is in the chat there as well. Thanks, everyone.